Welcome back to SurgiSmart, Cut to the Core. We break down essential surgical topics to help you understand surgical conditions. I'm your host, Major Munish Chauhan, and I'm a General Surgery Registrar in the British Army and at Oxford Deanery. I'm also a Senior Research Fellow at the Center for Army Leadership. Feel free to connect with me on LinkedIn if you have any questions or interest in these topics. Today we're taking a deep dive into esophageal diverticula, those pouch-like structures that can pop up in your esophagus. They can be a real pain, literally. You might be thinking, my esophagus, isn't that just a tube for food? Well, yes, but it's a pretty complex tube with muscles that work in a coordinated way to move food down to your stomach. When those muscles don't work quite right, or when there's extra pressure in the esophagus, you can get these little outpouchings forming in the wall, and those are our diverticula. The interesting thing is that these diverticula aren't all the same. They're classified by location, and that location actually tells us a lot about what might be causing them and how we need to treat them. We've got three main types to cover today: Zenker's diverticulum, mid-oesophageal diverticula, and epiphrenic diverticula. Let's start with Zenker's, the most common type. It's located right at the top of the esophagus, just above the cricopharyngeal muscle. Now, this muscle is a bit of a gatekeeper. It relaxes to let food pass into the esophagus, and then tightens up to prevent food from coming back up. But when this muscle gets a bit stubborn and doesn't relax properly, the pressure builds up and boom, you get a Zenker's diverticulum. What's fascinating about Zenker's is that it often presents with a classic triad of symptoms: dysphagia, regurgitation, and aspiration. Dysphagia is the medical term for difficulty swallowing. Imagine trying to swallow a piece of steak and it feels like it's stuck. That's dysphagia. And as the Zenker's diverticulum grows, that feeling of obstruction gets worse, making it difficult to swallow even liquids. Then we have regurgitation, which is undigested food coming back up. You know that feeling when you have a bit of acid reflux? It's a bit like that, except it's not just stomach acid, it's actual bits of food that haven't even made it to your stomach yet. This can happen hours after eating, and it's not just unpleasant, it can actually be quite dangerous. That's because regurgitation can lead to aspiration, which is when food or liquid goes down the wrong pipe and ends up in your lungs. Now, this can cause a whole host of problems, from coughing and choking to aspiration pneumonia, which is infection of the lungs caused by inhaling foreign material. So you can see why we need to take Zenker's diverticulum seriously. But how do we actually diagnose it? Well, the gold standard is a barium swallow study. The patient drinks a solution containing barium and shows up brightly on x-rays, highlighting the esophagus like a road map. As the barium flows down, we can see the outline of the esophagus and any abnormal outpouchings. For Zenker's, we'd see that classic posterior outpouching just above the cricopharyngeal muscle. We can also use endoscopy, which involves inserting a flexible tube with a camera into the esophagus. This allows us to visualize the diverticulum directly, but we have to be very careful because the wall of the diverticulum can be thin and prone to perforation. Now, once we've diagnosed Zenker's diverticulum, we need to decide on the best treatment option. And that's where things get interesting. We have both endoscopic and open surgical techniques at our disposal. Endoscopic stapling has revolutionized the treatment of Zenker's diverticulum, offering a minimally invasive approach with a much faster recovery time compared to traditional open surgery. Think of it like this. Instead of making a large incision in the neck, we can access the diverticulum through the mouth using a special endoscope equipped with a tiny stapler. The stapler divides the muscle fibers between the diverticulum and the esophagus, allowing food to pass more easily. It's a remarkable procedure, and the recovery is usually very smooth. However, there are cases where open surgery is still necessary. For larger diverticula, or when there are other complicating factors, the open approach might be the best option. The traditional open surgery for Zenker's diverticulum is called a cricopharyngeal myotomy with diverticulectomy. Let's break that down a bit. A myotomy means cutting a muscle, in this case the cricopharyngeal muscle, to relieve the pressure that's causing the diverticulum. And a diverticulectomy means removing the diverticulum itself.
So in this procedure, the surgeon makes an incision in the neck to access the esophagus and carefully removes the diverticulum. They then divide the cricopharyngeal muscle, allowing for smoother swallowing. It's a more involved procedure than the endoscopic approach, and the recovery takes a bit longer, but it can be very effective in treating Zenker's diverticulum. All right, so we've covered Zenker's diverticulum in quite a bit of detail. Now let's move on to the less common mid-oesophageal diverticula. While Zenker's is often caused by pressure from within mid-oesophageal diverticula, are usually caused by external forces pulling on the esophagus. Imagine scars from inflammation, for example, after tuberculosis. These scars can tug on the esophageal wall, creating a diverticulum. And here's where it gets tricky. Symptoms of mid-oesophageal diverticula can be all over the map. Some people have no symptoms at all, while others experience the classic dysphagia, chest pain, or regurgitation. It really depends on the size and location of the diverticulum and whether it's causing any obstruction or inflammation. To diagnose a mid-esophageal diverticulum, we again turn to the barium swallow study.
The barium outlines the diverticulum, showing its connection to the esophageal wall. Now here's the interesting part. Surgery is often not needed for mid-esophageal diverticula unless there are complications. If the diverticulum is small and not causing any problems, we might simply monitor it. However, if it's causing significant symptoms or complications, we might need to operate. And the type of surgery depends on the underlying cause. If it's due to those pulling scars, we might perform surgery to release the scars and relieve the tension on the esophageal wall. Or, if the diverticulum itself is large and causing obstruction, we might need to resect it, meaning surgically remove it. So for mid-esophageal diverticula, the approach is really individualized, taking into account the specific characteristics of the diverticulum and the patient's overall health. Okay, we've covered the upper and middle esophagus. Now let's head down to the lower end and talk about epiphrenic diverticula. These diverticula are located just above the diaphragm, that large muscle that separates your chest cavity from your abdominal cavity. And unlike mid-esophageal diverticula, they're usually caused by increased pressure from within, similar to Zenker's. But what's causing this pressure buildup in the lower esophagus? Well, the culprit is often a motility disorder. You see, the muscles in your esophagus have to work in a coordinated way to propel food down to your stomach. When those muscles aren't working properly, you can get abnormal contractions and increased pressure, which can lead to the formation of an epiphrenic diverticulum. And just like with the other types of diverticula, epiphrenic diverticula can cause a range of symptoms, including dysphagia, regurgitation, chest pain, and even aspiration. Diagnosing epiphrenic diverticulum, we once again reach for the barium swallow study. But in this case, we also want to assess the function of those esophageal muscles, and that's where manometry comes in. Manometry is a test that measures the pressure and coordination of the muscles in your esophagus. It's a bit like taking your esophagus to the gym and putting it through a workout. We can see how well those muscles are contracting and relaxing, and whether there are any areas of weakness or incoordination.
This information is crucial because if we're going to treat an epiphrenic diverticulum, effectively we need to address not just the diverticulum itself, but also the underlying motility disorder. And that brings us to surgery. The goal of surgery for epiphrenic diverticula is twofold. We want to remove the diverticulum, and we want to fix that underlying motility problem. Now, traditionally, this would have involved a large open incision in the chest or abdomen. But thankfully, we've come a long way with surgical techniques. These days, we can often use minimally invasive approaches like laparoscopic or thoracoscopic surgery. Laparoscopic surgery involves making small incisions in the abdomen, while thoracoscopic surgery involves making small incisions in the chest. We then insert a laparoscope or thoracoscope, which is a thin tube with a camera and surgical instruments attached, and we can operate on the esophagus through these small incisions. This means less pain, faster recovery, and fewer complications for the patient. So in the case of an epiphrenic diverticulum, we would use the laparoscope or thoracoscope to carefully remove the diverticulum, and then to address the motility problem, we often perform a myotomy.
Now remember how we talked about a myotomy for Zenker's diverticulum, where we cut the cricopharyngeal muscle? Well, in the case of an epiphrenic diverticulum, we're usually cutting the lower esophageal sphincter, which is the muscle at the very bottom of the esophagus that controls the flow of food into the stomach. By cutting this muscle, we can relieve the pressure in the lower esophagus and improve the flow of food, reducing the likelihood of the diverticulum coming back. In some cases, we might also add a fundoplication procedure, which helps prevent acid reflux from the stomach back up into the esophagus. So for epiphrenic diverticula, it's a two-pronged approach: tackling the diverticulum itself and addressing the underlying motility issue. And thanks to minimally invasive techniques, we can do all of this with much less disruption to the patient's body. It's really remarkable how far we've come in the surgical management of these conditions. So we've covered all three main types of esophageal diverticula: Zenker's, mid-esophageal, and epiphrenic. As you can see, they're quite different in terms of their location, causes, and treatment options. But one thing they all have in common is that they can have a significant impact on a person's ability to eat and enjoy food. Swallowing difficulties, regurgitation, and the risk of aspiration are serious problems that can affect a person's quality of life. That's why it's so important to understand these conditions, to be able to recognize the symptoms and to know when to seek medical attention. Early diagnosis and treatment can make a world of difference in the outcome for patients with esophageal diverticula. Now, you might be wondering, okay, so we've talked about the what and the how, but what about the why? Why do these motility problems occur in the first place? That's a great question. And honestly, there's still a lot we don't know about the underlying causes of esophageal motility disorders.
We know that certain factors can increase the risk, like aging, smoking, and certain medical conditions. But the exact mechanisms that lead to these muscle problems are still being researched. It's a fascinating area of study, and as we learn more, we'll be able to develop better ways to prevent and treat these conditions. But for now, we'll have to leave you with that thought-provoking question. We've covered a lot of ground regarding where these diverticula occur and what causes them. But let's delve a bit deeper into the diagnostic process. Remember how I mentioned the barium swallow study? It's a fascinating procedure that gives us a real-time view of your esophagus in action. Imagine this. You're lying on a table and you drink a solution that contains barium. Barium is a metallic compound that absorbs X-rays. So when we take an X-ray image, the barium-filled esophagus lights up, allowing us to see its shape and movement. As you swallow the barium, we can see it travel down your esophagus, and if there's a diverticulum, the barium will fill that pouch, creating a stark contrast on the X-ray. It's like watching a little balloon inflate off the side of your esophagus, giving us a clear picture of the size and location of the diverticulum. The barium swallow is the gold standard for diagnosing all three types of esophageal diverticula, but it's especially crucial for Zenkers. Now, we've also talked about endoscopy, which involves inserting a thin, flexible tube with a camera into the esophagus. This allows us to directly visualize the lining of the esophagus and get a close-up view of the diverticulum. We can assess its size, shape, and any other abnormalities, and if necessary, we can take biopsies to rule out other conditions. However, as we touched upon earlier, there's a risk of perforation with Zenker's diverticula because their walls can be quite thin. So we use endoscopy cautiously in those cases. Endoscopy can be a valuable tool for mid-oesophageal and epiphrenic diverticula, especially if we suspect other issues like inflammation or tumors. And for epiphrenic diverticula, remember that we often need to assess the function of those esophageal muscles. That's where manometry comes into play. This test measures the pressure and coordination of the muscles in your esophagus as you swallow. Think of it like attaching tiny pressure sensors along the length of your esophagus. As you swallow, these sensors detect the strength and timing of the muscle contractions, allowing us to pinpoint any areas of weakness or incoordination. This information is crucial for guiding our treatment strategy for epiphrenic diverticula, especially if we're considering surgery to address an underlying motility disorder. Okay, let's shift gears and talk about treatment. We've discussed surgical options, but it's important to remember that not everyone with an esophageal diverticulum needs surgery. In some cases, particularly if the diverticulum is small and not causing any symptoms, we might simply monitor the situation. Sometimes lifestyle modifications like chewing food thoroughly and avoiding certain trigger foods can help manage symptoms. But if those conservative measures aren't enough, or if the diverticulum is causing significant problems, then we start considering surgical options. And the exciting thing is that we have a range of surgical techniques available, from minimally invasive endoscopic procedures to more traditional open surgeries. Let's revisit each type of diverticulum and explore the surgical options in a bit more detail. For Zenker's diverticulum, endoscopic stapling has become the go-to procedure for many surgeons. It's minimally invasive, which means we can access the diverticulum through the mouth using an endoscope, avoiding a need for a large incision in the neck. The endoscope has a tiny stapler attached to it, and the surgeon uses this stapler to divide the muscle fibers between the diverticulum and the esophagus, essentially creating a wider opening for food to pass through. The recovery from endoscopic stapling is usually much quicker than with open surgery, and patients can often go home the same day or the next day. Now, there are also other endoscopic techniques like laser therapy or flexible endoscopic myotomy, which can achieve similar results. These techniques involve using a laser or a specialized cutting instrument to divide the muscle rather than a stapler. The choice of technique often depends on the surgeon's preference and expertise, as well as the specific characteristics of the diverticulum. But what if endoscopic techniques aren't suitable, or if the diverticulum is too large? Well, in those cases, we might recommend open surgery. The traditional open surgery for Zenker's diverticulum is called a cricopharyngeal myotomy with diverticulectomy. Remember, myotomy means cutting a muscle, and in this case, we're targeting the cricopharyngeal muscle, which is that stubborn gatekeeper at the top of the esophagus. And a diverticulectomy means removing the diverticulum itself. So in this procedure, the surgeon makes an incision in the neck to access the esophagus. They carefully remove the diverticulum and then divide the cricopharyngeal muscle, relieving the pressure that's causing the diverticulum to form. It's a more involved procedure than the endoscopic approach, and the recovery takes a bit longer, but it can be very effective for complex cases. Now, for mid-oesophageal diverticular surgery is often not needed unless there are complications. But if we do operate, it's often to address the underlying cause, like releasing those scar tissues that are pulling on the esophagus.
We might also perform a resection of the diverticulum if it's causing significant symptoms. And if there's an underlying motility disorder, we'll address that as well, potentially with a myotomy or balloon dilation. Let's finish up with epiphrenic diverticula. Remember, these are the ones located down low just above the diaphragm. And for these, our primary goals are to remove the diverticulum and address the underlying motility disorder. This often involves a laparoscopic or thoracoscopic diverticulectomy.
Remember, these are minimally invasive approaches using small incisions and specialized instruments. We remove the diverticulum and then perform a myotomy to release the tight muscle at the lower esophageal sphincter, which is often contributing to the pressure buildup. And that helps improve the flow of food and prevent recurrence. We might also add a fundoplication procedure to reduce the risk of postoperative reflux. So for epiphrenic diverticula, it's a two-pronged approach, addressing both the diverticulum itself and the underlying motility issue. It's amazing how surgery can address these intricate problems within the esophagus, wouldn't you say? It really is, and it's not just about the technical aspects of the surgery. It's about understanding the patient's individual needs and tailoring the treatment plan accordingly. For example, some patients might be better candidates for minimally invasive approaches, while others might benefit from a more traditional open surgery. We consider the patient's age, overall health, the size and location of the diverticulum, and any other underlying conditions they might have.
It's a very individualized approach, all about finding the best solution to improve their quality of life. Now, we've talked a lot about the different types of diverticula, their causes and treatments, but what are some of the potential complications that we need to be aware of? One of the most concerning complications is perforation, essentially a hole in the wall of the esophagus. This can lead to serious infections and other problems. It can be quite dangerous, which is why we're so careful during endoscopy, especially with Zenker's diverticula. And it's something we monitor closely after surgery as well. Bleeding is another potential complication, although less common than perforation. We also need to be mindful of the general risks associated with any surgery, such as infection, anesthesia complications, and the possibility of recurrence. It's important to weigh the risks and benefits carefully before recommending surgery. It's a decision we make together with the patient, ensuring they understand the potential complications and the recovery process. Speaking of recovery, what can patients expect after surgery for esophageal diverticula? Recovery time varies depending on the type of surgery performed.
For minimally invasive procedures like endoscopic stapling or laparoscopic diverticulectomy, patients can usually go home the same day or the next day. They can usually return to a normal diet fairly quickly as well. For open surgeries, the recovery period is longer, often a few days in the hospital and several weeks to fully recover at home. In most cases, surgical treatment for esophageal diverticula is successful in relieving symptoms and improving quality of life. However, there's always a small risk of recurrence, especially if there's an underlying motility disorder that isn't fully addressed. So it's important for patients to follow up with their surgeon after surgery to monitor their progress. Regular follow-up appointments allow us to assess their recovery, check for any signs of recurrence, and address any concerns they might have. Esophageal diverticula, while complex, are treatable conditions. And with advancements in surgical techniques and a better understanding of the underlying causes, we're able to offer patients safer and more effective treatment options than ever before. The key takeaway is that esophageal diverticula are not a one-size-fits-all condition.
Each type presents differently and requires a tailored approach to diagnosis and treatment. By understanding the nuances of these conditions, we can provide our patients with the best possible care and help them regain their ability to swallow with ease. Well, I hope you found this deep dive into esophageal diverticula informative. If you have any questions or want to delve deeper into this topic, feel free to connect with me on LinkedIn. Until next time, keep learning and exploring the fascinating world of surgery.